My name is Arthur Lurvey. I'm on the board of PCRI, also on the board of CPCC, California Prostate Cancer Coalition, and I've worked with these organizations for 10 to 15 years.
As a prostate cancer patient and the medical director for a Medicare contractor, you must have some fairly strong opinions about prostate cancer screening, diagnosis, and treatment. Are we overtreating prostate cancer today?
Well, I think there may be a subset of patients who might do well with careful observation and surveillance over time. As was mentioned in the program today, with certain selected characteristics, low-grade biopsies, and careful observation, some of these patients may be able to have less invasive treatment, but that's a subset of patients.
Where do you stand on prostate cancer screening related to healthcare reform? Do you believe, as many do, that access to PSA testing will be restricted by the reform process because of overdependence on the current guidelines of the U.S. Preventative Services Task Force?
To begin with, I don't know all the fine details because the healthcare reform is still in a great flux, and there are a lot of considerations, and it's 1,000 pages or more. I don't think that prostate cancer screening will be restricted because screening in general is supposed to be covered, and over the years more and more screening has been permitted and built into the Medicare program, and I suspect that there'll be more and more screening to prevent disease in whatever does come out, if anything comes out of Congress.
It is clear that prostate cancer treatments are going to be a target of comparative effectiveness research. Do you think that it will be possible to execute studies that will actually allow us to determine whether any form of treatment for localized prostate cancer is better than any other?
Well, I think at the meeting we've had this weekend and others that prostate cancer is not one disease but multiple diseases depending on the patient's background and genetics, depending on the possibly the age of the patient and the type of cancer cell. So I believe that comparative effective studies within subgroups of patients would be very helpful because we would like to know if one form of radiation treatment or one form of cancer chemotherapy is better than others for that subset. Information, particularly information that we collect, is always helpful. Whether we use it, that depends on the individual patient and doctor. But the getting of information, the acquisition of scientific information is something to be sought after.
How do you think about the need to ensure that men are appropriately educated to understand their risk of prostate cancer? It is clear that most men are still woefully ignorant, even by the time they come to a doctor for their first PSA test. Can we change this significantly?
The various cancer coalitions in the prostate cancer community has done a number of things to try to interest men. They've gone to barbershops in some communities, they've gone to churches in some communities, they've tried to have the women bother their husbands or spouses or significant others, and all of which have been somewhat helpful. I think that in the community where more and more people have electronic communications, the internet, the various forms of social networking, that more and more people will be exposed to it, and I think exposure is what will bring up the idea. As we see on television, more and more drugs and conditions are advertised, so people become more aware of it. And even conditions that have various emotional connotations have been brought up on television. Urinary problems, sexual problems. I think that more and more information will get to people, and then they'll be more active in their own personal surveillance.
How do you think about the diagnosis of prostate cancer in men over the age of 75? Clearly, many such men do not need either diagnosis or treatment. But how can we best identify the ones who do?
I think that the treatment of patients depends on the entire patient. What is selected for them depends on how healthy they are. We're all living to be an older age. We're all living healthy to be an older age. Prostate cancer is a condition that affects men of older age, but taken into context with their whole body. Do they have other conditions that might preclude, say, surgery would be a consideration. I think screening should be continued at all ages, and I think that the understanding of all diseases in the elderly should always be paid great attention for, because we're all going to be elderly, and the average age is rising. When Medicare started, the average age was 64. Now I believe the average age of people is between 84 and 90, depending on the sex and perhaps their genetic background. So I think that age should not be a determinant in deciding who or who not to treat.
What, in your opinion, is the most important information prostate cancer patients should know?
Well, I think the biggest information to patients has to be that if they do find out that they have prostate cancer, there are many, many options and types of treatment, that it can be very slow growing, that taking care, paying attention to physicians and their family is very important, that many of the decisions are theirs. They have a right to choose what is best for them. And until we know exactly of all the treatments, which is most protective, then they should take the treatment that works best for what they believe they want out of life.